Hello, and welcome to the AMA's Steps Forward podcast series. We'll hear from healthcare leaders nationwide about real-world solutions to the challenges that practices are confronting today. Solutions that help put the joy back into medicine. AMA's Steps Forward program is open access and free to all at stepsforward.org.
Hello, and welcome to this episode of the AMA Steps Forward podcast series. I'm Dr. Margaret Lozavatsky, Vice President of Digital Health Innovations here at the AMA, and your host for today's episode, where we will be discussing AI governance. As healthcare organizations increasingly adopt AI in various ways, establishing clear governance and oversight structures has never been more important. To support this effort, the AMA has developed the Steps Forward Toolkit on AI governance, providing practical guidance and building a strong governance framework. The toolkit outlines key steps for success, including establishing leadership and structure, aligning AI initiatives with strategic goals, developing policy, ensuring proper training and education, as well as continuously evaluating AI's impact. As part of this toolkit, we are highlighting a few healthcare organizations that have had success in AI adoption and implementation. Joining us to discuss this topic is Dr. Srinivasan Suresh, who is the current CIO, CMIO, and Vice President at UPMC Children's Hospital of Pittsburgh. Thank you for being here, Dr. Suresh. Before we get started, would you mind telling our listeners a little bit about yourself and your background?
Sure. Thank you, Dr. Lozavatsky, and to the AMA for this opportunity. I am Srinivasan Suresh. I go by Suresh. I'm a pediatric emergency physician at UPMC Children's Hospital in Pittsburgh. I serve as a Vice President and Chief Medical Information Officer of the hospital. I have a faculty appointment as a Professor of Pediatrics with the University of Pittsburgh. My scope of responsibilities are our electronic health record and related technology applications, patient portal, digital health, and now artificial intelligence and machine learning-based tools. I'm involved in a few funded research projects involving electronic clinical decision support. I'm fortunate to work at a top-ranked children's hospital. We have over 1.4 million patient encounters annually, and we are part of a large 40-plus hospital health system, UPMC, which is an integrated payer-provider organization and also an academic medical center.
Wow, that's fantastic. Well, let's jump right into our conversation on AI governance. Can you describe UPMC Children's Hospital's journey with AI governance?
Sure. It's still evolving. Our AI governance team is very multidisciplinary. It's led by UPMC's Chief Data and Analytics Officer and comprises of clinicians, IT leaders, legal and compliance experts, and other technology professionals. We approved a policy in October 2023 on acceptable use of AI technology. It's a 5-page document. We started off with some definitions. What is an AI assistant? What is generative AI? What is LLM? What is machine learning, etc.? So outline basic ethical considerations and regulatory obligations. So we provided a step-by-step approach to our approval process. What is the internal IT support? What are the guidelines for AI development, configuration, and use? And this policy is signed by our Vice President for Privacy and Information Security, who is a lawyer by background. Related to this policy, we have a smaller 2-page document which talks about AI tech standards, what are the requirements for AI assistants, how will third-party software be assessed by our enterprise architecture and information security team. So that is the structure we have for governance. And as you can see, the policy was created almost a year and a half ago, and we are in the process of updating that.
Well, that's fantastic. I love that you started with some clear definitions. How do you guys think about prioritizing augmented intelligence?
That's a great question. I wish we could go back a few decades and replace the term artificial intelligence with augmented intelligence, especially in healthcare, where, as you know, in most scenarios, we always want the human in the loop, whether it's a doctor, nurse, pharmacist, as appropriate, because sometimes there is a negative connotation to the term AI as an artificial intelligence. Augmented would have been better. To answer your question, in our place, the proposal for the AI-driven solution should come from a clinical champion and not from a software vendor, period. We are very particular about that. So that helps us prioritize the various projects that come to us from various clinical champions. And then we figure out what's the clinical need, what current pain point does it address? Is there a research component to it or a hospital operations improvement component to it? So that's the framework we currently go with.
Well, that's fantastic. I love that you guys keep the clinicians at the center of your prioritization process. What role has leadership, including your CEO and your executive teams, played in championing AI governance at your organization?
Sure, I would answer that in one word, as appropriate. Appropriate. They're always there for our support, but they appropriately defer to our IT and AI teams for the deep dives and final decisions because of the structure. Not just for generative AI, but even before the widespread, talk and adoption of AI-driven tools, even for our other IT initiatives, just because our teams and the decision-making group is very multidisciplinary, our leadership, my CEO, to whom I report to, and our exec teams defer to us.
That's great. So I want to talk a little bit about liability and risk. We hear a lot of folks with concerns about data privacy, algorithm bias, liability. How do you think about that at UPMC?
Yeah, these are very important points. Let me take those one at a time. The algorithm bias, it's really important to review the training data that goes into a model. Are there any underrepresented groups? How do we deal with that? Just because an AI model worked for children in California, as an example, does not mean it will automatically work for my patients in Pittsburgh. There's certainly more awareness, though, now. When these AI models are built and refined, we need to ensure that the sample that is used to create the model, just to pick an example, sepsis identification in children, should be representative of the population of patients that's being applied on. Although, given the nature of this technology, most of the development is in large academic centers, Harvard, Stanford, etc. So that itself is perceived, whether it's true or not, as biased. You mentioned data privacy and liability. We are so fortunate to have experts in our information assurance teams who have dealt with those domains for decades in our IT EMR world before generative AI. So we engage them as needed. We also have patient care representatives in our various quality and safety work groups. We actually have a board member who regularly attends our clinical quality oversight community meetings. So we certainly take their opinion and feedback. But to reiterate a point made earlier, the role of the clinical champion is vital for us. If we don't have a clearly identified clinical champion who is making the case for a new AI driven tool for clinical care, research, hospital operations, patient engagement, whatever the case may be, then we will not move forward.
Well, as a pediatrician, I can certainly appreciate the importance of testing these algorithms on our smallest of patients. And I really appreciate the fact that you guys have been so thoughtful in including both patient feedback and clinician feedback in your governance model. Are there any use cases that stand out at UPMC Children's Hospital as being highly successful or that you're especially proud of?
Sure, I'll mention one, and I use this myself in my practice in pediatric emergency medicine. It is ambient conversation recording to the clinical note. And I feel this is a very practical use of AI. The audio recording of the conversation between me and the patient or the caregiver taking the history and the physical exam. This is done using a secure app on the smartphone. And once the recording is done, within just a minute later, a draft of my ED note is made available. The note, which is pretty accurate, still needs to be reviewed by myself and finalized. But the value here is the time saved. And we started this less than a year ago, and now more than 200 of my colleagues, not just physicians, but also advanced practice providers, are using this. We've had close to 25,000 patient encounters, I think, where we have recordings. And to repeat what I said earlier, the value here is the time saved. In my practice, when I use this tool, it takes me about a minute or 2 minutes max to review my recording and the note, as opposed to 5 to 6 minutes if I were to create the note without the use of this AI-driven tool. So 4 minutes per patient encounter, 20 patients during an emergency medicine shift, it adds up. So that's a value.
That sounds like a dream that I think we all hope to have the ability to use at some point. What is your vision for scaling AI tools across UPMC, and what factors are going to be critical for your success? So, in other words, how are you going to be measuring the success of these tools?
Yeah, another great question. This again is still evolving. We don't have a finalized list of, let's say, key performance indicators for this. We look at this as what could be the structure outcomes, what could be the process outcomes, and go from there. One way of answering this is the need or the necessity to have the AI tool integrated into the EHR, which is critical. If it's not, it's really a hard sell to the clinicians to use, something which is needs another browser to be opened, or another application to be opened. And when we look at integration of generative AI into the EHR, the broad categories, and this is how we would eventually measure success. These are still early stages. I gave one example of ambient recording, and we have a few more, 3 or 4 more AI driven projects. But overall, we look at, if integrated into the EHR, will these simplify documentation? That's the example I gave. 2, will it improve communication? 3, we are looking at chart summarization, and 4, automating any actions, not just for the physician, but also for nursing and any allied staff. So I don't have specific performance indicators to provide, but eventually we'll look at, can we easily define the value to the clinician and value to the patient? If you're not able to answer those questions, then we are not successful.
Well, those are very important success metrics. I appreciate thinking about both the clinicians and the patients. We know that AI is becoming very integral in care delivery. And I think the question that we're all grappling with is, how are you balancing this increased use of AI and thinking about how it aligns with the strategic initiatives of UPMC?
Yeah, you're right. It's a balance, and it's a tricky balance. The technology is developing much faster than we can finalize or refine, the ethics, compliance, and the policy adherence part. So it is definitely tricky. But we go back to the basic tenets. We need to make sure we safeguard patient privacy, ensure data integrity, and fall of the regulatory frameworks. Another take on that is, every technology, Gen AI is so much in the news, but every technology before that has downsides. We can spend a lot of time just going over the barriers and challenges and constraints, but there is evidence that AI driven apps have improved productivity and efficiency in healthcare. It enhances clinician workflows, it improves patient engagement, speeds up a lot of back office functions. So we really need to expedite finalizing the governance structure. I think we have a good one, but we still need to get it, so right, so that we are not delaying the realization of true value. We also need to realize that eventually the clinician treating the patient is responsible for any patient harm that arises after the AI tool. It's not the developer or a regulating body or the software vendor. So we keep that in mind too.
Well, thank you. All very important pearls. Any other thoughts that you'd like to share with our audience? Any lessons learned as you're navigating all of these AI implementations at UPMC?
Sure, yeah. If I can mention a few points. One is, you asked about the details of our governance structure earlier, and sort of related to that, we gave it a thought that, should we do this AI governance on our own, or should we be collaborating with other similar organizations or the private or the public sectors? And we do need to collaborate on that, in that sense, with our major technology partners, with the vendors that host our cloud services, with our EMR vendors. And at UPMC, we are fortunate to have UPMC Enterprises, which is our in-house entrepreneurial and commercialization venture that partners and sometimes invests in startups and mid-stage companies. So if we are using their AI-based products, it is essential we look at their governance structure as well, not just UPMC's, so that the trial or the proof of concept that we do with these companies are beneficial to our clinicians and patients. So that is one point. Another one which is interesting, which is this point has been sort of doing the rounds lately, is how can AI be best adopted to not inappropriately deny patients care? And I believe there are some lawsuits regarding this too. As the use case scenarios are being implemented and we develop, proof of concepts and trials and pilots to do these, I heard this related to what your question in some webinar, that most patients may wonder if their physician used AI that may have not been fully tested in their care. And if that did not work, should that MD be liable for that? But what if, this is what I feel is interesting part, what if the MD had access to an AI driven tool and did not know about it or chose not to use it in the patient's care? Will he or she be liable then? So that's another question we are just trying to grapple with. The last point I'll make is, when you ask for any other pearls of wisdom, so I will state this, and putting on my hospital administrator hat, is not to deviate from our mission, vision, and goals. We have to include technology and digital tools and generative AI in getting there. That's great. But there may be some scenarios where, AI is not the answer, and we should be cognizant of that. We just should not lose sight of the values of our organization. And the last point is to focus on execution. Implementation of a lot of what we talked about is pretty hard. And then most of us do not need more ideas, but just need to focus on our goals, governance goals, our roadmaps, and then just go ahead and execute.
Thank you. All very important points. Thank you for sharing your successes at UPMC. It sounds like you guys have a really great foundation in thinking through how to take the new technology and target it to what our patients and our clinicians need. Thank you, Dr. Suresh, CMIO at UPMC Children's Hospital of Pittsburgh. He has been our guest today. Check out the episode description to explore the resources mentioned in today's episode. And until next time, stay well.
Thank you for listening to this episode from the AMA's Steps Forward podcast series. AMA's Steps Forward program is open access and free to all at stepsforward.org. Steps Forward can help put the joy back into medicine by offering real-world solutions to the challenges that your practice is confronting today. We look forward to you joining us next time on the AMA's Steps Forward podcast series. stepsforward.org.